Hi, my name is Margaret Pellizzari. I'm the Assistant Nurse Manager and Program Coordinator of Pediatric Endocrinology at Cohen Children's Medical Center. Our team consists of pediatric endocrinologists, our fellows, nurse practitioner, diabetes nurse educators, nutritionists, as well as our social worker. Diabetes is a medical condition that requires ongoing office visits as well as education to families and patients. Our team is here to help you along the journey for your initial education until the transition when you go from pediatric diabetes care to adulthood. Type 1 diabetes is an autoimmune medical condition whereby the cells that are producing insulin are being destroyed. There is what's called a gradual onset of type 1 diabetes. And by the time somebody does actually get diagnosed with type 1 diabetes, 90 to 95% of the cells that are producing insulin have been destroyed. Diagnosis criteria for diabetes would be a fasting blood sugar greater than 126 milligrams per deciliter, or a random blood sugar test, that means any time of the day, greater than 200 milligrams per deciliter. In addition, hemoglobin A1C is a criteria for diagnosis of diabetes if that hemoglobin A1C value is greater than 6.5% in adult populations. A hemoglobin A1C is a test that is done and measures the overall blood sugar readings 24/7 for approximately the last 2 to 3 months. It is given as a percentage and then correlates to average blood sugar readings. Prediabetes is defined as a blood sugar 101 to 125 milligrams per deciliter. Normal fasting blood sugars are defined as a blood sugar less than 100 milligrams per deciliter. There are genetic predispositions to developing type 1 diabetes. In addition to a genetic predisposition, researchers found that there are some environmental or perhaps viral triggers that puts one at risk for developing type 1 diabetes. The prevalence of type 1 diabetes is 1 in every 300 to 400 persons, and it is increasing yearly. The risk of developing type 1 diabetes is 4 to 6% if a parent already has type 1 diabetes. That risk also doubles if that parent developed diabetes before age 11. In type 2 diabetes, there is a different genetic predisposition to this medical condition. It is marked by insulin resistance. The cells are producing insulin, however, the insulin is not being utilized properly. Type 2 diabetes may occur more frequently in those individuals who are overweight or obese. Please note that type 1 diabetes and type 2 diabetes may occur in the same family. Acanthosis nigricans is a skin marker that is usually noted for those individuals who are insulin resistant. To review, type 1 diabetes is an autoimmune medical condition whereby the cells that produce insulin are not producing that insulin. And onset usually occurs before age 21. In type 2 diabetes, it is noted by insulin resistance, whereby the cells are producing insulin, however, we see elevated blood sugars. Signs and symptoms of diabetes may include frequent urination, with sometimes waking up in the middle of the night to urinate, feeling tired, feeling thirsty, perhaps having a weight loss, and perhaps blurry vision. The diabetes management plan includes intensive diabetes education, home blood glucose monitoring, insulin administration, healthy eating and carbohydrate counting, and exercise or activity. Why is it important to achieve target blood sugar? The DCCT, or the Diabetes Complication and Control Trial, conducted by the National Institutes of Health, was a landmark 10-year study that showed that tighter control of blood sugars could minimize the risks of complications related to eye disease, kidney disease, and nerve damage. Why monitor blood sugars? Number one, for safety, to know where the blood sugar level is. You will know your results within seconds. This will help you to know how to adjust your insulin. It will also help you understand the effects of food, activity, illnesses, and stress on your blood sugar readings. Blood sugar monitoring also provides a sense of control. You should check your blood sugars before your meals, before bedtime, anytime you're not feeling well, before activity. You should be checking blood sugars more frequently if you are not feeling well and if you're ever vomiting. Please note the chart on the following slide. The American Diabetes Association Clinical Guidelines recommends the following blood glucose target ranges as well as A1C goals based on a child's age. There are many blood glucose meters out on the market. Many times what is recommended for your child would be what insurance companies use as their formulary meter. When you have a new meter, you need to make sure that you set the correct date and time. Instructions are written in the manual, and if you need further assistance, you can always call the 800 number that's on the back of the glucose machine. You make sure that the child's hands are washed, or if you're going to use an alcohol swab, make sure that then the finger is dried. So we make sure that the finger is dried before we actually access some blood with the finger stick so that the water is not mixed with the blood that would give us a diluted sample. We're going to load a new lancet in the lancing device and use a clean lancet each time you're going to be checking the child's blood sugar. You take a strip out of the bottle, and as soon as you take a strip out, you should close the cover so that humidity does not get inside and alter the reagent strips. Once you stick the strip in the meter, there's usually an icon that notes that it's time for some blood to go on. The places where you can test for blood sugar is the sides of the finger. We don't usually test blood sugars on the pad of the finger because that's where the nerve endings are and it would hurt more. In each lancing device, there is usually a depth control. When you read the owner's manual or speak with your diabetes educator, they will discuss that further. Usually the lancet devices are spring-loaded devices. You get a drop of blood, you allow gravity to help you get that blood, and you squeeze until you see a big enough drop of blood to go on the test strip. When we see that we have a big enough drop of blood, we'll get some blood on that strip, and then in seconds we're going to get a reading. When we get that blood sugar reading, we can log that in a logbook. The blood glucose meters also have memory and will give you average blood sugars, usually for the first 7 days, 30 days, and perhaps 60 or 90 days. On the screen of this blood glucose meter, you can see that the 7-day average blood sugars are 179 milligrams per deciliter. A lancet should be used one time only. When we're disposing a lancet, it should be disposed of according to the New York State law, which means it must go in a puncture-proof container. If we're out, we can do something like this, where we are putting it back inside the cap, so it looks like this, and the new lancet looks almost like a telephone. Hello! Proper disposal of the sharps once you get home would be placing it in a puncture-proof container, such as a laundry detergent bottle or any other puncture-proof container. We are going to ask that families enter blood sugar readings as well as insulin doses in a logbook. Here's one sample of a logbook, and here's another sample of a logbook. Blood glucose readings can be downloaded from your meter and can then be emailed to the diabetes team for review. Glucose control solution usually comes with your blood glucose meter set up. This can be used if there is ever concern that your test strips may not be accurate. You would test the test strip using glucose control solution, and note that it would be in the range that's noted on the test strip canister. If you have any questions or concerns about your blood glucose meter, please feel free to call the toll-free number located on the back of your blood sugar meter. Continuous glucose monitoring systems allow us to identify trends in blood sugar patterns. When one is wearing a continuous blood glucose monitoring system, what's needed is a sensor. A sensor is a wire placed underneath the skin, and then a transmitter is placed on top of that. Most sensors are placed in using a spring-loaded device such as this one. In addition to a sensor and the transmitter is a receiver of the information. With this continuous monitoring system, we can depict trends in blood sugars as well as identify patterns and have predictive alerts and alarms as one's blood sugars are trending up or possibly trending down. This allows one to take immediate action. This system is called the Dexcom system. Another system in the United States is the Medtronic. This is actually the transmitter for the Medtronic glucose sensor. When we download data from the glucose monitoring systems, we're able to see graphs such as this one. Looking at graphs, we're able to identify trends in blood sugar patterns and thus make any insulin adjustments along the way. This next graph depicts what normal physiologic insulin secretion profile looks like in an individual who does not have diabetes. Their pancreas is producing insulin all the time. That's considered their basal or baseline insulin. And when that individual eats, their pancreas produces more insulin in response to the carbohydrate content. This next graph then depicts the ideal insulin profile. We are going to administer an insulin injection of a basal insulin that's called Lantus or Levemir, and then we're going to give bolus of insulins before meals called Humalog, Novolog, or Pedra, and that will help to match the insulin to the carbohydrate ratios as well as bring blood sugars back to target range. Insulin is a hormone produced by the pancreas. Insulin allows sugar to enter the cells so that one can have energy. When there is not enough insulin, the sugar cannot get in the cell to be used for energy. The sugar then builds up in the bloodstream and is peed out in the urine. Insulin must be injected underneath the skin. Why is it important to rotate insulin injection sites? By rotating insulin injection sites, you will be able to maintain healthy tissue. You will be able to minimize hardened or scarred areas. If you have hardened or scarred areas, the insulin may not be able to get absorbed properly, and you may get blood sugars that are erratic. I'd like to introduce you to Rufus and Ruby. The places where we can do insulin injections are the back of the arms, the tops, the sides, or the back of the legs, the belly, staying 1 inch away from the belly button, as well as to the outside of the belly and the love handles. And if we use the buttock or hip area, it would be the upper outer portion of that area. When rotating insulin injection sites, we ask that families rotate within one area for approximately 1 week first, before moving on to another area for the next week. Our basal or baseline insulins are Lantus or Levemir. They are clear in appearance. They start working in approximately 1 hour, and we think that they are lasting about 24 hours. They should be given at around the same time every day. Lantus or Levemir insulins cannot be mixed with any other insulins. Our bolus insulins are Novolog, Humalog, or Apidra. These are usually given before a meal, and the purpose is twofold. One, we usually give to address carbohydrates that will be consumed at the meal, and the other will be to help get blood sugars back within the target range. These bolus insulins Our rapid-acting insulins, they start working within 5 to 10 minutes and are working their hardest within 1 hour. We think these insulins are lasting anywhere from 3 to 5 hours. Insulin to carbohydrate ratio is determined for each individual. An insulin to carbohydrate ratio is the amount of insulin given to cover a certain amount of carbohydrates. An example of an insulin to carbohydrate ratio would be this. Let's say an individual has an insulin to carbohydrate of 1 unit of Humalog, Novolog, or Apidra insulin for every 25 grams of carbohydrate. And let's say this individual will be consuming 75 grams of carbohydrates. We take the 75 grams of carbohydrate, divide that by the insulin to carbohydrate ratio. This would then give us 3 units of insulin. How do we know if one's insulin to carbohydrate ratio is correct? We're going to make sure that that individual is doing good carb counting. Then we are going to ask them to check a blood sugar 2 to 3 hours after they give that insulin for those carbohydrates. We can expect to see a 30 to 40 milligrams per deciliter rise in blood sugar readings. If blood sugars are not within that target range, that individual may not be getting the right amount of insulin, or perhaps they may be miscalculating their carbohydrates. A correction factor is determined on an individual basis. The correction factor is the amount of insulin needed to drop the blood sugar to the target blood sugar range. For example, let's say that this individual has a blood sugar of 200 milligrams per deciliter, and their insulin correction factor or sensitivity factor is 1 unit of insulin, Humalog, Novolog, or Apidra, to lower their blood sugar by 50 milligrams per deciliter. And let's say that their target blood sugar is 150 milligrams per deciliter. We take the starting blood sugar reading of 200 milligrams per deciliter, subtract the target blood sugar of 150. That gives us 50 milligrams per deciliter of blood sugar that we need to make a correction. If we take that number 50 and divide it by the correction factor of 50, that gives us 1 unit. So they would need 1 unit of insulin to get them back into target range. From the previous example of our carbohydrates and the correction of 1 unit, put those two together, 3 plus 1, that individual will need to take 4 units of the Humalog, the Novolog, or the Apidra insulin before their meal. Blood sugars can be corrected every 3 hours. Our insulin pens or vials that are in use need to be kept at a controlled room temperature, and our extra insulin will be kept in the refrigerator. Supplies that are needed to give an insulin injection using an insulin pen device. Our insulin pen, a brand new insulin pen needle, and an alcohol swab. Before we start, we make sure that we clean our hands by washing them with soap and water and drying them very well. If you do not have access to the sink, you may use Purell or hand sanitizer. We're going to take off the cover to our insulin pen. We're going to take an alcohol swab and clean the rubber stopper for the pen device. We're going to take this paper shield off the pen needle, screw it onto our pen, take off the outer cover, and then take off the inner cover. Please note that these small pieces to the pen may be choking hazards to small children. Every time we put on a new pen needle, we must dial up to 2 units to get out any air and to make sure that insulin is ready to be in the insulin pen needle. So here we have 2 units. This is what's called an air shot. And we shoot that up into the air until we see a nice stream of insulin. And then we would dial the dose. So let's use the example from the previous slides that we needed 3 units of insulin for the carbohydrates, and we needed 1 unit of insulin to get us back into a target blood sugar. That was 4 units of insulin. We're going to dial to 4 units. I'm going to take a clean alcohol swab. I'm going to give an injection in my belly. I'm going to find the area. I'm going to clean in to out and never back in again. And I'm going to let it air dry. Before I place the pen needle underneath my skin for the injection, I'm going to make sure that I can see the window of the dosing dial. I'm going to be pinching up my skin and straight in and quickly put the pen needle underneath my skin. I'm then going to go to the top here and press down and push all of the insulin in until I see that the dial is at 0. While still putting my thumb on the top of this device pen, I am going to count to 10. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. After the 10, I'm going to take this out. I can take my alcohol swab and just press on the area. With the outer cap, I'm going to place that on there and unscrew this pen needle. This used pen needle will then go in the Sharps container that I have at home. I will then put the cover on my pen and put it away until it's time to be used again. Please make sure when storing your insulin pen that is in use that you do not store it with an insulin pen needle at the end of it. Leaving the insulin pen needle on while it is not in use may cause insulin to leak out or air to enter into the cartridge. Insulin pumps eliminate the need for frequent insulin injections. An insulin pump is a battery-operated, computerized, pager-sized insulin delivery system. You need to have a reservoir to hold the insulin. Goes to a tubing anywhere from 23 to 43 inches in length, and then with usually a spring-loaded device, a needle gets inserted underneath the skin that holds then the catheter. The catheter stays in place and the needle gets removed. We change infusion sets every 2 to 3 days. There are different types of insulin pumps. This one is the one-touch Animas Ping. The insulin is held in the reservoir here to the tubing. The infusion set is underneath the individual skin. That gets changed every 2 to 3 days. This is what an infusion set looks like. This one is called an inset. What also comes with the Ping is the one-touch Ultra Smart meter that would allow for one to bolus remotely. So let's say I was wearing an insulin pump and I put it in my pocket. And then I checked my blood sugar using the one-touch Ping. I can then bolus for my meal and bolus for my correction if needed remotely. This is a Medtronic insulin paradigm pump. This also has tubing and a reservoir. And we have an Omnipod pump. This pump does not have any tubing. The insulin gets housed in the bottom of the pump in the reservoir in the pod. The pod gets placed on the skin, and then one can use this PDM, Personal Diabetes Manager, to check blood sugars as well as bolus remotely. Hyperglycemia is high blood sugar. The causes of high blood sugars could be not enough insulin, miscalculating carbohydrates, illness or stress can make blood sugars go high, or decrease in activity level may also lead to high blood sugars. Signs and symptoms of high blood sugar would be the same signs and symptoms as diagnosis of high blood sugars with diabetes. Feeling thirsty, feeling tired, making a lot of urine, blurry vision, feeling hungry, and perhaps having a weight loss. One needs to make sure that their insulin is good and has not gone bad. When blood sugar readings are greater than 250, 2 readings in a row for no obvious reason, one needs to check for ketones. Ketone bodies are waste products that develop when there is not enough insulin. A way to check for ketones is either by the urine or by the blood. Keto sticks are purchased at the pharmacy. You either urinate in the cup or you pass the strip through the stream of urine. After 15 seconds and the directions are written on the back of this canister, you shake off the excess urine and you match it up to the color chart. It's normal to have negative ketones. Trace or small ketones, one needs to drink a lot of water to try to flush those waste products out of the body. Moderate or large ketones, we ask that you please call us on the emergency line. Somebody is available on the emergency line 24/7. Another way to check for ketones is by the blood. There are 2 machines right now on the market that allow for blood ketone testing. One of them is the Precision Extra by Abbott, and the other one is the Novomax Plus. So we're going to check the blood for ketones, and ketone values of less than 0.6 are normal. 0.6 to 1.5 is moderate. Have the child drink a lot of water. Any blood ketone level above 1.5 millimoles per liter, we would like you to please give us a call on the emergency line. Vomiting may be a sign that one has ketones. If your child is ever vomiting, we ask that you check for ketones as well as a blood sugar and call us immediately on the emergency line. Elevated blood sugars over extended periods of time will cause high A1C readings. Please note the chart as well as the child's age and the American Diabetes Association clinical guidelines for recommended target blood sugars as well as A1C values. If your child becomes sick, you may need to take him or her to the pediatrician for evaluation. Please check blood sugars more frequently. Please make sure that insulin doses do not get skipped. If you're not sure to give the amount of insulin that's usually given, please call us and let's discuss what would be the plan for sick day management that day. Also note that if your child is vomiting, please check a blood sugar as well as a ketone and call us on the emergency line. If your child is not eating well while he or she is sick, please give us a call so that we can discuss. Perhaps we may need to adjust that insulin dose. Never skip an insulin dose completely. Diabetic ketoacidosis results when there is not enough insulin. Signs and symptoms of diabetic ketoacidosis could include nausea, vomiting, high blood sugars, flushed skin or red in the face, paleness, being very thirsty, and perhaps having abdominal or stomach pain. Please check blood sugars as well as blood ketones and give us a call on the emergency line. Rapid, shallow breathing like this, or sweet, fruity odor to the breath may be signs of diabetic ketoacidosis. Hypoglycemia is also called low blood sugar. It can be defined as a blood sugar less than 70 milligrams per deciliter. It usually comes on suddenly. Signs and symptoms are different for each individual, but usually include shakiness, sweatiness, difficulty to concentrate. Some children may be very tired. Some may say they're hungry. Some may say that their legs feel weak. What to do if one suspects a low blood sugar? One should check the blood sugar to confirm what exactly is that reading. Treatment of low blood sugar includes 15 grams of a rapid-acting glucose source, such as 4 ounces of any kind of juice, or 1 cup of milk. Milk has natural sugar called lactose. Another source of 15 grams of fast-acting carbohydrate would be glucose tablets. Glucose tablets were specifically designed to assist with raising a low blood sugar. Glucose tablets come in different flavors. A glucose tablet looks like this. Looks rather large. Glucose tablets are scored, and if you have a younger child, you can actually break it in half. Once put in the mouth and start to chew, they're easily dissolvable, actually very delicious, and taste almost like a sweet tart. The treatment, though, is 4 glucose tablets. Glucose tablets also come in a tube of 10, and this is easy to carry in your pockets, in your purse, to keep in the glove compartments, to keep at the bedside table. After treating a low blood sugar, it may take 10 to 15 minutes to start feeling better. If you're still feeling like the blood sugar is low, please recheck in 15 minutes, and if it's still less than 70, you may take another 15 grams of rapid-acting glucose source. Nighttime low blood sugars may occur. Symptoms that your child or infant may be having a low blood sugar during the nighttime may include waking up from a nightmare, yelling and screaming and being disoriented, moaning, restless sleeping patterns. Children may also report that they feel that their heart is racing or beating very fast. Please check your child's blood sugar if any of these symptoms develop, and call us if the blood sugars are noted to be low in the middle of the night. It may be possible with activity that a blood sugar could drop. To prevent a low blood sugar before activity, please check that blood sugar. Please give your child approximately 15 grams of carbohydrate for every 45 minutes of activity, along with some fat and protein. Some examples of a 15-gram carbohydrate snack could be cheese and crackers, peanut butter and crackers, apple with some peanut butter, milk, or yogurt. If blood sugars continue to drop during activity and you notice this as a pattern, please give us a call so that we can help you to make insulin adjustments. Please discuss with your child when he or she experiences his or her first episode of low blood sugar. So this way, everybody becomes aware of what that individual is experiencing during a low blood sugar episode. Individuals who take insulin and have diabetes should wear a medical identification noting that they have diabetes and take insulin. This is just one example of a medical alert identification bracelet. Here are some other examples of medical identification jewelry. It is highly unlikely, but possible, that one may experience a severe low blood sugar, resulting in unconsciousness and perhaps seizures. one should do if your child or adolescent has a severe low blood sugar is to administer glucagon. Glucagon comes as an emergency kit in either a red or orange container. Glucagon should be stored at a controlled room temperature. The expiration date is noted on the bottom of the package. Inside this glucagon emergency kit, we have a syringe filled with liquid and a freeze-dried glucagon tablet. We flip this cap off. We take the needle cover off. We insert the needle to the vial and put all the liquid inside. We swirl this until it becomes clear. We put our needle back inside the vial. It's a longer needle than what would be used as an insulin syringe or for your pen needle. Flip this upside down and take the dose that's recommended. For individuals greater than 3 years old, you would use the whole dose. For children aged 3 and less, you would use half of the dose. Get the air bubbles out. This glucagon injection should be given the same way one gives an insulin injection, or better yet, in the muscle. Muscle is located at the top of the arm here or on the upper thigh area. Give it straight in and give the recommended dose. After one administers the glucagon dose, please place your child on his or her side. A side effect to glucagon could be nausea and vomiting. It takes about 5 to 10 minutes for the glucagon to work. Once your child wakes up, please check his or her blood sugar, give him or her something to eat, and please call us on the emergency line. We would like to know what happened, how it happened, and how we can prevent this to happen in the future. If you cannot find your glucagon emergency kit, or if it's expired, you can use glucose gel. You would open up the package of gel, put the gel on your finger, and then insert the gel inside the child's gums in there and rub the cheek. Do this until you use all of the gel that's in the package. Please do not open this up and squirt it in the mouth of somebody who is unconscious, because the concern could be choking. Please continue to use the full amount of the glucose gel. If you cannot get it in the inside of the mouth, at least be able to get it on the child's lips so that the glucose gel will be absorbed through the mucous membranes, allowing blood sugars to rise. Initial diagnosis of diabetes may come as a shock and be very overwhelming. Feelings of guilt, anger, denial, sadness may all be present. Our diabetes team is here to help and support your family during this difficult time. We help encourage good diabetes care habits of blood sugar monitoring, carbohydrate counting, the role of insulin administration, insulin dose adjustments, as well as the role of activity. Our center is an affiliate center for TrialNet. TrialNet is an international research study testing the autoantibodies of other families to see if they may be at risk of developing type 1 diabetes. If an individual is at a great risk for developing type 1 diabetes, there are interventional studies in which one may enroll. Researchers are also investigating to see if there are other interventions which may help with the new diagnosis of diabetes. What does the future hold? Future treatments may include stem cell research, islet cell transplant research, artificial pancreas, closed-loop insulin pump, insulin delivery system, along with glucose sensor. Please see the following website for further clinical trials. As an American Diabetes Association recognized education program, it is our responsibility to make sure that our families have outside resources. Please see some of the following outside resources to help assist families. Please be careful when using the internet to gather information. Make sure that the site is a trusted site. If you are not sure, please feel free to ask the healthcare provider. We are here to continue to provide outpatient care and support as well as education. Some of those classes include carb counting workshops, insulin pump information classes, toddler and young children's support groups, advanced insulin pump classes. We are part of the American Diabetes Association's Safe at School programs, where we offer classes to discuss 504 accommodations, which means not discriminating against the children who have diabetes while in the school. We provide a yearly class for school nurses, school teachers, and coaches. We provide social work intervention. We are available by telephone as well as email communication. The American Diabetes Association, along with the National Diabetes Education Program, endorse a smooth transition from young adulthood to adult diabetes care. During adolescent and young adulthood, your diabetes care team will help provide support and education with regards to risk-taking behaviors, how to manage diabetes and sex, diabetes and alcohol, other drugs, smoking, driving, and going away to college. Thank you for taking the time to view this video. Please feel free to use it in the future as a resource. Please feel free to share it with your family and friends. Your diabetes team is here to help you and guide you through your pediatric and adolescent years, as well as your transition years to adult diabetes care.